Hello, and welcome to this webinar on indocyanine green use in colorectal surgery and some of the landmark studies. A special thanks to Diagnostic Green for supporting this educational session today. Before we get started, a few housekeeping reminders. This webinar is being recorded, and as long as we've got consent from all speakers, it will be available afterwards. Feel free to submit questions, and we do encourage you to ask questions as we go along. Please use the Q&A function. It's better to ask questions as we go along, and we'll try to address them as we go along in the responses. Do follow ESSO on social media. So what is ESSO? Basically, we've got more than 4,000 members. We run educational grants. We have certification programs and in-person courses and webinars. We also have an annual congress, and the next one is due next year in Madrid, in Spain, between the 4th and 6th of November 2026. And we look forward to seeing you there. So why join ESSO? You have you basically get access to knowledge, and you have webinars like this that are run, and also the courses. You've got publication advantage that you get 30% discount on all open access fees, and you also get subscription to the ESSO, which is really nice to have. There's career growth opportunities if you have eligibility for the educational grants and exchanges. And also there's research opportunities where you've got access to experts, and it's quite nice to get to the Congress because it's a really good opportunity for networking, but also to setting up sort of collaborative projects together. And I think now that we're in more and more of global education and global healthcare, this is an absolute great advantage for anyone. Another course I wanted to mention was the ESSO hands-on course on the colorectal cancer surgery. So those are the main things from myself. And so our first speaker today is Professor Alex Weimer, and he's here from Leiden University Medical School. And he's going to talk about AVOID, a phase 3 randomized control trial using indocyanine green for the prevention of anastomic leakage in colorectal surgery. Sorry, just hand over to you.
Yeah, thank you very much for the kind introduction, and also the opportunity from ESSO and Diagnostic Green to present our results from the AVOID data. I think it's a very nice webinar with three very large randomized trials that are presented today, and maybe at the end of the webinar we can take a decision whether or not it should be standard of care as of today. Over the recent years, there has been a lot of discussions about the use of ICG to prevent a colorectal anastomotic leak. There's a very nice consensus paper from EIS on this topic, where it was shown from small non-randomized trials or also very other trials that there might be some benefit by using ICG to prevent an anastomotic leak. What was lacking at the time was the large trials, randomized trials that can show whether or not there's real benefit. So as of the Netherlands, we had the AVOID trial organized only in the Netherlands, and it was aimed as a randomized design to show in all colorectal cancer resections that there might be benefit by using ICG. So not only the left-sided but also the right-sided resections were also included in this trial. These are the hospitals in the Netherlands, so they were all large colorectal cancer or colorectal surgery teaching hospitals. So there were both academic hospitals and non-academic hospitals, but they all had a very the number of patients were quite high in these centers. So the goal was, of course, to assess the colorectal perfusion, so the perfusion of either the colon or the rectum with the use of ICG. We had a fixed dose of 5 mg of ICG. The assessment was within the first 60 seconds after the administration of the ICG, and only patients were included in this trial which were either operated on by minimally invasive surgery or robotics. Of course, robotics is also minimally invasive surgery, but it was either using the Olympus system or the Da Vinci system from Intuitive. and that was both benign and malignant cases. The primary endpoint, which I will present today, were all clinically relevant leaks, so both B and C taken together as one group, and then and we did it, of course, within the first 90 days. So based on the power calculation to reduce the risk of a leak from 13 to 7%, we roughly needed about 1,000 patients in this trial. Just to show you how the trial was performed. So the surgeon, he or she, will just point where the anastomosis should be, or where the colon should be divided, and then ICG was administered, and it was clearly documented whether or not there would be a change in surgical management based on the fluorescence. So in this case, you can clearly see that there was a change in surgical plan. So the first point of resection of the colon, then you can see that it's still non-well perfused. Just two other examples to show you the two different patients are this. So one on the left, of course, there you can see the stitch by the surgeon is on the right spot. And in the different patients on the right side, you can see that the ICG fluorescence is roughly about 1 centimeter below the stitch of the surgeon. So in that case, of course, a surgical procedure would be changed to make the anastomosis in the well perfused. So in this case, the green area. So between July and February, so also in the COVID period, we were able to include the 1,000 patients. And at the end of the day, when you look into the enrollment of the patients and the randomization process, we roughly had the similar amount of patients in each group. So 163 on one hand, and then 486 on the other. So 463 versus 468 on the other by using ICG or no ICG in a randomized fashion. Then if you just look at the groups, there was no difference in the groups. Male, female was the same, BMI was the same, diabetes or other risk factors was the same. And what we found, of course, is that the procedure, so the operating time by using ICG was slightly about 10 minutes longer than without using of ICG. So that is, of course, it is also as part of the trial design. So setting up the camera system, infusing the ICG, our PhDs were around. So it took some time. So that's a significant difference by using ICG. So then to the anastomotic leakage rate. So we were, of course, hoping to see in all patients that there might be benefit by using ICG, but it was not the case. So in the overall group, if we take the whole group together, and it was the main endpoint in the Lancet Gastroenterology paper, so therefore on the abstract, we were only allowed to show the main endpoint, and the endpoint was, of course, for the whole group, there's no difference if you look at the p-values. So both the with ICG group, the FGBA, so with fluorescence-guided surgery group versus the other, there's no significant differences in the 90 days leak rate and also not in the 30 days leak rate. Was there a change in surgical management? Yes. So we had roughly in about 41 patients, there was a change in surgical management by making the anastomosis on a different spot of the colon or the rectum. And you can see that still in that group, still 4 patients developed an anastomotic leak. And if you identify the patients into various areas of the resections, if you only look at the right side of the resections, so we had 397 of 79 patients, and then you can see that in this group, so that you have the fluorescent-guided anastomosis and the control, that there's no difference. So you can see that there's no difference between yes or no leak, and the p-value, of course, is 0.96. So there's clearly no benefit by using ICG in the almost 400 patients that we included on the right side. If you then look at the left side of resections, and that's also, of course, then you can see that there is a difference. So in the left side of resections, you can see that we have in the fluorescence-guided surgery group, we have roughly about 8% leak rate versus 13% in the control group, and that is, of course, statistical significant. If you then look at the sigmoid and the rectal cancer resections only, so that's more or less maybe comparable to the other speakers of today, so the inclusion of patients, then we had 440 patients, and then a similar result. So we found a statistical significant difference in this subgroup analysis, of course, between the ICG positive group and the ICG negative group. So you can see 8.6% leak rate when you use ICG, so BC leak. And without ICG, it is 14.7, and that's a significant finding. Other complications between the groups were just the same, so we didn't find other complications. There was no, other than the differences in leak rate, we could not find any other complications if you just look at the whole group. And that's so the admission rate was the same, the mortality rates were the same between the two groups. Yeah, is it important? Well, we think it is, because if we know that there was a nice paper from the Amsterdam group by Roel Hompers and the team that they showed clearly that an anastomotic leak is very expensive. It ranges a little bit between 2,000 euros, which I thought was very cheap, up to 80, which I believe is more like a number that it can be for the in-hospital costs by having additional days in the hospital and additional ICU days. So I think that's really important, of course, by sparing only one leak will in the hospital save you a lot of money on your budget. But also we're talking about the environment, and the environmental impact of one leak is extremely big. I didn't know, but you have roughly about 1,300 kilos of CO2, a lot of waste, and even water. So you have 1,800 cubical meter water, which is impacted by only one leak. So if you then look, of course, at the numbers needed to treat, yeah, then to make more like a case that it is helpful, then the number is only about 16, and that's based on the fact that the imaging systems are available, so that can be different among the various countries. And ICG is not very expensive, so if the systems are available and ICG is not expensive, and then you see these numbers, then we think you should do it. So take a little bit. Do I think that we have enough evidence? Well, we have still 2 talks to go, but at the end of the end of the webinar, I hope that we can answer the question whether or not there are still research needed, or that we think that we have enough results that we can put it in both the national and the international guidelines. Now, the important point that we are assessing at the moment is whether or not green is green. So whether or not we need quantification. So I will not show you any data, but that's in our trial, the next step, where we can find whether or not, the quantitative analysis of the data help, or can even inform us better about whether or not there's a leak expected. So this is just a trial, the Avoid Study Group from the Netherlands, and thank you very much for your attention. And I think we do the questions maybe at the end of the webinar, or if there are questions now, I'm happy to answer them as well.
Thank you so much, Alex, for that wonderful introduction and your details of the studies that you've been involved with. Our next, we'll take all the questions at the end because we can have a lovely discussion as well, which is really helpful. So our next presenter is Professor David Jane, and he's going to talk about intraoperative fluorescence angiography with the Indocyanine green to prevent anastomotic leaks in rectal cancer surgery. So over to you.
So thank you very much, Afsana, and thank you for the opportunity to present our work at this this really interesting webinar. So I'm going to speak about a UK coordinated study, and this was called the INTACT trial. It was funded through our National Institute for Health and Research. It was a European study because we needed 30-odd centers to recruit the patients. So it was a very simple study design. It's a 2-arm parallel randomized controlled trial. Importantly, it only included patients with rectal cancer because we believed that this was the population at greatest risk of an anastomotic leak. And if we were going to see a benefit for ICG, it was probably in this population. So patients were randomized to either white light laparoscopy or laparoscopy with Indocyanine green. They were followed up for 4 weeks with various clinical, health economics, quality of life outcomes. Importantly, at 4 to 6 weeks, it was mandated that every patient had to have a rectal contrast study. And that was because we were very interested in the grade A, the subclinical leaks. And the only way to really pick those up was with a contrast study. And then the final analysis step was at 90 days follow-up. So the primary endpoint was the rate of clinical anastomotic leak. And we defined these according to the International Study Group for Rectal Cancer. So grade B requires some form of intervention, but not a return to theatre, whereas grade C requires a return to theatre. Our secondary outcome, and it was a key secondary endpoint, was all anastomotic leaks. So in addition to B's and C's, we included those grade A anastomotic leaks, and those are the leaks that you can either are subclinical, they are picked up incidentally, or they might need reasonably minor treatment with antibiotics or something like that. Other secondary endpoints included, as we've seen very eloquently in the videos before, this change in the level of the planned anastomosis. We were interested in all complications, hospital stay, re-interventions. We had some functional outcomes because, as we all know, surgery for rectal cancer does have significant quality of life effects, particularly in terms of bowel function. So we included the LARS score, and we included a health economics analysis. So to be eligible, you had to have a rectal cancer, which we defined as being 15 centimeters or less from the anal verge. And you could have TME resection of your cancer. It could be laparoscopic, it could be TA-TME, it could be robotic. We weren't prescriptive about how the surgery was done. We were focused, concentrated on how the anastomosis was performed, and in particular, the use of ICG. So we hypothesized that based on current evidence at that time, that with the use of ICG, the clinical anastomotic leak rate could be reduced from 12% to 6%. And based on that hypothesis, we needed 880 patients. And to provide us with those patients, we needed 25 centers split between the UK and Europe. We built into that power calculation an interim analysis at 554 patients. So this was performed totally independently by an independent data monitoring committee. And when we got to that point, the data monitoring committee came back to us and said, look, we don't think you need to go to 880 patients. We can't justify that. We think you need 766. So that ended up as our final sample size. So in the interest of time, I'll skip straight to the results. This slide shows the baseline characteristics of our two populations. And what you'll see is there's no difference in the population not having ICG and the population having ICG. So we see the predictable mix between males and females, which you'd expect, slightly more males for a rectal cancer population. Importantly, patients weren't being selected for this study, so it wasn't the easy patients that were being put in here, and that's reflected if we look on the proportion of patients who get neoadjuvant therapy, so around 40–45%. And also if we look at the stage T3 to 4, so about 60% of patients had locally advanced cancers, and around 40% of those cancers were below the peritoneal reflection. So we believe this study cohort reflects the general practice of rectal cancer surgery. Our primary endpoint, as I said, was the rate of clinical anastomotic leak. So if you go to the bottom table here, you can see that in the standard care arm, that's those patients not receiving ICG, the leak rate was 15.2%. In those who did get ICG, it reduced to 10.5%. And if we look at the modeling behind that, we see that unfortunately it didn't quite reach statistical significance for clinical anastomotic leak rate. It very nearly did, and if you look at the 95% confidence intervals, they only just breach the non-significant level. Reassuringly, we see in this modeling that other groups who you might predict would have more leak are also represented here. So females who have a wider pelvis had less risk of a leak. Those tumors above the peritoneum, they also had a reduced risk of leak. If we look at our secondary endpoints, so this is all anastomotic groups, grades A, B, and C. And again, if we go to the bottom table in this slide, we see without ICG, the leak rate is 20.8%. So that's almost 1 in 5 of our patients are having some kind of leak following rectal cancer surgery. And that will decrease to 13.7%, which we found when we used the ICG. If we look at it by the different grades of leak, so this is the top table in this slide, we can see actually there was no difference in the grade C leaks, and that these changes we were seeing both in the clinical anastomotic leak rate and also in the overall anastomotic leak rate, it's being driven by differences in the grade A and the grade B leaks. So we can see between the IFA and no IFA arms for grade A and B that it's about half the rate of leak if you have ICG. And this just shows the statistical modeling. It's similar to previously, but this time the difference in the leak rate is highly statistically significant. We looked at the change in the planned anastomosis because we had to understand why we might be seeing these differences in the leak rate. And what we saw is if you gave ICG, you changed your plan in 12.5%, whereas without ICG, you were less likely to change your plan, only in 7.0%. And if we look at what was behind that change in the original plan for the anastomosis, we see that the difference was in the plan for the proximal transition level. So that's in the middle of this chart. So if you used ICG, you changed your proximal level in 6.7% of cases as compared to only 3.0% without ICG. The same didn't hold true for the distal end, the rectal stump. So there was no difference between the two arms, and only 1.6% of cases was there a change in the level of the division of the rectal stump. Interestingly, on this population-based analysis, what we see was that more patients in the IFA group actually ended up with a permanent stoma. So with the use of ICG, it appears that surgeons were deciding some of the time actually not to do an anastomosis. It was too risky, and they were doing a permanent stoma instead of an anastomosis. And that compares to about half that rate without ICG. When we look at the complications, we see probably the difference in the leak rate being reflected in the complication profile at 90 days. So we see more complications without ICG, 44.9%, and that reduced to 38.5% at 90 days when you use the ICG. We looked at reinterventions within 90 days. And again, this seems to support the findings, the difference between the two groups. So in the standard care group, intervention rates were around 21.7%, and they reduced with ICG, probably due to the lower leak rate, to 17.6%. We also included a cost-effectiveness analysis. This was conducted just on UK NHS hospitals, and it had to be that way because One, our funders wanted that information, but also healthcare systems and remuneration rates differ around Europe. So it included 345 patients, and it took the 90-day time horizon, which was the study follow-up period. So we collected quality of life at baseline, at 30 days, and at 90 days. And we looked at healthcare utilization, and that wasn't just in the hospital, but it was also in secondary and community care. So it involved prescription charges, district nurse visits, visits to the GP. So it was a whole social perspective that it was taken from. What we found is that there was very little difference in the quality of life. So even though we saw that difference in the leak rate, the difference in the quality of life between the two groups was really quite marginal. And that might have something to do with the fact that we were seeing more A's and B's rather than C's in the cases where there had been a leak. This shows the costs. So overall, the costs of the operation were cheaper with the ICG by around £300 to £400. And the main difference between the two groups in the costs was the primary admission. So at the time when the leak could have occurred, that's when the difference in the costs seemed to be occurring rather than perhaps out of hospital costs. In the UK, our healthcare is promoted or otherwise by our National Institute for Health and Care, NICE, and they have a threshold to pay of £20,000. So if you look at our health economics analysis and you look at NICE's willingness to pay threshold at £20,000, that's the dotted line going up vertically, and you can see that there's around a 60% chance that NICE will support this and that it has a net health benefit. And that encompasses all those assumptions that take place in any health economics evaluation. So in summary, we found that ICG reduces the incidence of all anastomotic leaks in rectal cancer, that the effects seem to be dominated by a reduction in the grade A and B leaks, and it seems to be supported by the findings that there was more likely to be a change in the anastomotic planning, in particular the proximal resection site. So I'll leave it there now, Afsana. Thank you for listening.
Thank you so much, David, for such a wonderful presentation. In view of time, what I'll do is I'll do the next presenter. There's a few questions that are coming in. So I will just ask everybody if you could use the Q&A function so we can start answering them as they come in, as opposed to the chat function. So our next speaker is Professor Jun Watanabe, who will be speaking about blood perfusion assessment by ICG imaging for minimal invasive rectal cancer surgery and the quantitative assessment study. Over to you, Jun.
Thank you. Thank you very much for kind introduction. I'd like to express sincere thanks for giving me the opportunity to make my presentation. So I'd like to start my presentation from my disclosure. So the essential trial was designed to evaluate whether the use of ICG fluorescence angiography to assess the blood perfusion of anastomotic site could reduce the incidence of anastomotic leakage in minimally invasive rectal cancer surgery. So this was a multi-center phase 3 randomized controlled trial conducted in Japan. And eligible patient had resectable rectal cancer less than 12 centimeters from anal bulge and was scheduled for minimally invasive surgery with sphincter preserving. So laparoscopic and robotic and TATME were eligible. Patients were randomized 1-to-1 ratio in two groups, ICG group and control group. So the primary endpoint was the rate of grade A, B, C anastomotic leakage within 30 postoperative days. So planned sample size was 850 cases. So ICG injection timing is just before the anastomosis. Injected 12.5 milligram per 5 milliliter of ICG. Sorry. So ICG injection timing is just before the anastomosis. Injected 12.5 milligram per 5 milliliter of ICG. And near-infrared laparoscopic camera system is Stryker 1588 or 1688. We defined the fluorescence is observed up to the planned transition line less than 6 seconds as good perfusion. So in case of poor perfusion or no perfusion, after the identification of good perfusion zone and additional resection is performed. I will show you the video of the procedure. So ICG was injected intravenously just before anastomosis. So the dose of ICG was 12.5 milligram. So observed by near-infrared laparoscopic camera system. So normally fluorescence observation take approximately 30 seconds from intravenous injection and defined as good perfusion. Simultaneously, we also check the perfusion of the rectal stump. So we define the delayed fluorescence more than 60 seconds as poor perfusion. And in such case, the transaction point was changed to more proximal side to have good intestinal perfusion by near-infrared ablation. The total of 850 patients were enrolled from 41 centers. 11 patients were excluded, and a total of 839 patients were included in the modified ITT analysis set. So this is the result of the primary endpoint and grade ABC anastomotic leak rate. The incidence of anastomotic leakage was significantly lower in the ICG group compared with the control group from 11.8% to 7.6%. The relative risk reduction was about 35%. So this is secondary endpoint. The anastomotic leak rate for grade BC was significantly reduced from 8.2% to 4.7%. The time from ICG administration to fluorescence and bowel wall was 25 seconds. And the rate of additional bowel resection due to poor intestinal perfusion was 2.4%. The reoperation rate decreased significantly from 2.4% to 0.5%. So this is a summary of results of the 4 phase 3 randomized controlled trials. So in AVOID trial, subgroup analysis shows significant reduction in anastomotic leakage in the left column, including both benign and malignant tumors. And INTACT trial, although not statistically significant, there was a reduction in grade BC anastomotic leakage from 50.2% to 10.5% in rectal cancer, less than 15 centimeters from inner bulge. And ICG CORAL trial, although not statistically significant, subgroup analysis show a reduction in anastomotic leak from 9.5% 5% to 5.6% in the left column, including both benign and malignant tumors, excluding low anterior resection. In all randomized controlled trial, there was a consistent trend showing that ICG fluorescence reduced anastomotic leak in left colon or rectal cancer. So next step is quantitative analysis. So quantitative blood flow assessment is expected to further improve the accuracy of blood flow assessment by ICG fluorescence method and contribute to further reduction of anastomotic leak. Currently, the clinically available instrument for quantitative measurement of fluorescence is Stryker's 5QP system. So this device automatically measures the time from the onset of fluorescence until the fluorescence intensity reach a plateau. So that is the Tmax. And it is also capable of quantifying fluorescence intensity. So reference point for fluorescence value is the most proximal portion of the large bowel that extends outside the body. In this case, the time from the onset of fluorescence until the fluorescence intensity reach plateau, that is Tmax, was 16 seconds. And the quantitative value of the anastomosis site is 80 to 90%, confirming that there is a sufficient blood flow. So in this case, the time from onset from fluorescence until the fluorescence intensity reached the plateau. So now calculated the Tmax value. So this case is Tmax is 16 seconds. So, and now measure the quantitative value of the planned anastomotic site. So in this case, so this site is anastomotic planned transaction line. So planned transaction lines fluorescence value is only 10 to 20%, confirming that there is insufficient blood flow. So this green area has a quantitative value of 20 to 50%. And this area was also judged to have insufficient blood flow. So finally, we transact the colon in this portion. So quantitative value are 7 to 100%. And this area was judged to have a good blood flow. So this line is the planned transaction line. So this line is the revised transaction line. In such cases, it is difficult to accurately determine the transaction line using qualitative ICG fluorescence assessment. I think that quantitative ICG fluorescence allow for the identification of area with sufficiently good blood flow, thereby enabling the accurate determination of the transaction line. So our retrospective study evaluating the effect of quantitative blood perfusion assessment by SPY-QP software on anastomotic leak after low anterior resection for rectal cancer has been published in Surgical Endoscopy. So data from around 200 patients who underwent low anterior resection for rectal cancer were collected. So finally, anastomotic leak rate was only 3%. So the rate of shifting the transaction line were 8.5%. So this circle is a breakdown of the additional resection reason 3% was no perfusion, and 2.5% is perfusion time over 60 seconds. So these can be determined through the existing qualitative assessment. However, there were 3% of cases where additional resection was performed due to decreased fluorescence quantitative values. These cases could not be determined by qualitative assessment alone and become identifiable through quantification. So therefore, quantitative ICG analysis may potentially reduce anastomotic leakage by approximately 3%. So this table shows the correlation between Tmax and the time from fluorescence expression to this is the Tmax. And this range is the time for perfusion fluorescence after ICG injection. So both parameters are well correlated. So time for perfusion after ICG injection was median 30 seconds, and the Tmax was 80 seconds. Correlation coefficient is 0.55. However, there are occasional cases where the Tmax is measured within 30 seconds, despite the fluorescence duration in the intestinal wall exceeding 6 seconds. So this indicated that Tmax measurement alone may not always be sufficient to determine adequate blood flow. So the conventional criterion of 60 seconds or less from ICG intravenous injection to intestinal wall fluorescence must also be used. So this figure on the right shows the relationship between Tmax and the fluorescence value. So the case with the Tmax of 30 seconds or less were anastomotes with quantitative value exceeding 60. So case with quantitative value below 60 underwent additional resection and were anastomotes at site with higher quantitative value. Therefore, case within the red zone may not exhibit anastomotic leakage and blood flow is considered adequate. So case with Tmax 31 to 40 seconds were anastomotes with quantitative value exceeding 70. Case with quantitative value below 70 underwent additional resection and were anastomotes at the site with higher quantitative value. So case within the yellow zone may not exhibit anastomotic leakage and blood flow is considered adequate. So finally, we make from these retrospective results, we made the algorithm, so SpyQP software, by using SpyQP software for quantitative blood flow evaluation like this. So we are currently conducting the spectacle study, prospective single-arm confirmatory study to verify whether quantitative assessment using SpyQP with a developed algorithm can further reduce anastomotic leak. So we also prospectively enrolled 400 patients to verify whether the anastomotic leak incidence rate is significantly lower than the 7.6% observed in the ICG fluorescence group of the ESSO trial. So, and the results are expected to open early next year. So in my conclusion, the phase 3 essential study met the primary endpoint and demonstrating the superiority of a blood flow assessment using ICG fluorescence imaging compared with conventional blood flow assessments in minimal invasive surgery for rectal cancer. So these results support ICG fluorescence imaging is recommended for the prevention of anastomotic colorectal cancer. So moreover, so next step is a quantitative blood flow assessment is expected to further improve the accuracy of a blood flow assessment by ICG fluorescence method and contribute to further reduction of anastomotic risk. Thank you for your attention.
Thank you, Jean. Jean, that was really wonderful presentation. What we're going to do is ask all the speakers. Sorry, let me just have some water. I'm going to ask all the speakers to come back. We're going to have a little discussion. So first we'll pick up some of the questions that came in. So the first question was, can you explain appropriate ICG dose? And I noticed, Alex, it came in during your talk, so I don't know if you want to address it first.
Yeah, so we use a fixed dose, so not the independent on body weight. So we use 5 mg in all patients, and also now in the quantitative trials, so where we do quantitative fluorescence imaging, like Yoon also showed, we use a similar dose. So always a fixed distance and 5 milligrams, and then we record 3-minute videos. That's for research purposes. But for just clinical use, we have only 5 milligrams total dose that we use in all patients.
And Jun and
dose.
David, is yours a similar experience as well?
So we do on body mass, so we use 0.1 milligrams per kilogram. The vial usually comes with 25 milligrams, so that gives you enough for 3 shots.
Okay.
So we usually do it twice, and then we like to have some people like to do, I like to do an endoluminal assessment after the anastomosis. Not everybody does that, but you have the option.
Thank you. And Jun, what about your experience?
Yeah, and we use 12.5 milligram per body. So, I think up to laparoscopic near-infrared camera system. So, an Olympus, Striker, Stoltz, and Da Vinci, Firefly, and different. And if using the Striker camera system, and we set the ICG fluorescence intensity, we change. So, and brightness parameter and gain parameter. So 2 parameters exist. So this up to these parameter, ICG dosage change.
Thank you so much for that. The next question, David, came in from your whilst you were doing the talk, and it was about a question regarding the use of ICG in patients with hyperthyroidism, and what's the recommendation in these cases?
We would use the same dose. You know, patients being operated on for who've got thyroid disease, you'd hope that their thyroid would be controlled before you operated on them anyway. So we would use the same dose.
Yeah. And then the next question that came in, David, again, it was during your presentation. It's quite interesting for this one, and which I want other people's experience on as well. And it's, what's your opinion on hand-sewn versus stapled anastomosis, which gets better results? And the ICG, is it much more important to perform during the anastomosis? And what's the difference between the two of them in your experience?
So our study, the INTACT study, was all rectal cancer. So I don't know anybody now who does a hand-sewn rectal cancer anastomosis. The old evidence would suggest that there isn't any difference between the two. I think there might be some interesting evidence emerging on techniques to deal with the dog ears of the doubles. People worry about if you do a double staple anastomosis, whether it leaves dog ears and perhaps they increase the risk of leaks. So there are techniques for dealing with that, which I think there's some interesting evidence emerging from that. So I think that's somewhere we'll watch this space, really.
Okay. Does anybody else want to comment on that as well? Alex, would you?
No, I fully agree with David. And we in our trial didn't look specifically to whether or not it was hand sewed or stapled. But again, for the right side of the resection, there's a possibility that some surgeons use the hand sewed. but that's something that we didn't take into the analysis. And in the end of the day, there was no difference among the groups on the right side. So, and all the others were most of the time stapled.
Yeah, thank you.
Right.
And during your presentation, there was a question about ICG use and if the dose is adjusted. We've actually addressed that earlier. So I've got a question actually, which I think would be really nice because we've got a really lovely international faculty. So if I ask David first, what is your knowledge or experience of ICG use in your respective country? So in the UK, what's your experience of ICG use? Is it being used everywhere or in only a few centres?
No, it's not being used everywhere. I wouldn't know the actual penetration of it, and if I was to give you a figure, it would be based on my best guess and my conversations with people. I think it's used, some surgeons use it religiously all the time. Some will tend to use it selectively, and some still believe that there's no place for it. If it's bleeding, it's fine. You don't need the ICG. I would think the uptake is slowly increasing, but it's slow. And certainly it would be less than 50% of people at the moment who are using it. And I think this is part of the problem with ICG, that in one of the slides that we've just seen, we saw numbers needed to treat of 16. And that's part of the problem. You do it 15 times, it doesn't make a difference. And so people get a bit bored and think, well, does this work? But as soon as you've had the one, it really comes home and you learn the lesson. And yes, there is a value to this.
Thank you for that, David. And Alex, would you like to give me your experience?
Yeah, I think also in the Netherlands it's increasing. So it's not used in all hospitals, but I think that at the moment increasing. And that's also based on the fact that more hospitals have the imaging systems available. So I think 5-6 years ago, there were only a few systems out, but now the quality of either Storage, Striker or Olympus, Intuitive is just great. So they offer it most of the time standard on their systems. And that's a big improvement. So and as you've seen today in all the pictures from the various systems, it just looks very good. So imaging systems, the quality is better. Penetration is better in the Netherlands. So that's of course very dependent on the country. As I showed you before, from the Philippines, we heard there's only one system over there in the whole country. So in the Netherlands, we're very fortunate that we have more. But still, we have surgeons that use the ICG in our trial, the AVOID trial, and that of course had a favorable outcome, and afterwards don't use it all the time. So something is there that also David pointed out that surgeons don't always use it, but yeah, although they know of course that that there might be benefit.
Thank you. And your experience, do a lot of centers use it in Japan? And what's
Yeah.
your experience?
Thank you. So when the ESSO trial began in 2018, so penetration rate is only 10%
I see.
in Japan. However, now, so near-infrared camera system is not widespreading. Almost all hospitals have near-infrared laparoscopic camera system. And so open the result of the ESSO trial. So now penetration rate is over 80%. So, and one more reason is, there is one more reason. So one more reason is the ICG cost. So in Japan, the ICG is very inexpensive, only 3 or 4 euro. One buyer, 3 or 4 euro. And government insurance coverage is, so we use the ICG for blood flow perfusion. So government paid to the hospital about 30 euro.
Yeah, so this is one of the things, isn't it? One is equipment, as we've heard from Alex. The other thing is just the practice that we've got, and then obviously from yourself regarding the costs that are involved. There's a really nice question that's coming. It says, do the experts feel that the uses of ICG in open lap and robotic surgery, the site of colonic cut, is different as the magnification increases from open to robotic open to robotic surgery. The magnification is different. Shall I ask you, David, first to answer that one?
You can do. I think the answer is no. Mainly because we do our robotic resections, we mobilize the bowel, we divide the bowel, but actually the anastomosis we still do the assessment and the anastomosis, you know, under laparoscopy really. So we will do the mobilization, we will still exteriorize the bowel, we will still resect it, and you're doing that sort of visually, and then we'll put the bowel back, and I'll usually use the laparoscopic camera, but not connect the robot to it to do the anastomosis. So for me, I don't think it will influence things.
Alex, what about you? Oh, sorry, you're on mute.
Yeah, I fully agree with David. I think it's the same. Yeah, absolutely. I feel the same as David.
Thank you. And another question that's come in, are there any contraindications of ICG use? So would you like to go with that first, David? Sorry, Alex.
Yeah, so it was of iodine, of course. Allergy to iodine was one of the questions. Yeah, we still do it, of course. So we still don't use it then, but I don't know how strong the evidence is. I think maybe other surgeons will just use it as normal, but we don't. But that's only in our center. So we ask for shellfish and iodine allergy, and then we don't use it. So that's but I don't know if that's still accurate.
Jun, from your perspective, is that the same?
Yeah, and the same.
Okay.
Allergy.
Yeah. Okay. And David?
Yeah, exactly the same. I mean, they do talk about, again, I have no idea whether there's any truth in this or not, but they do say that you have to inject it in water and not saline, because you can get aggregation in saline, and it's the aggregation that perhaps is problematic.
Okay, thank you. I'm going to draw a close to the actual webinar. And before I do that, I would like to say a huge thank you to the lovely speakers, so Professor Alexander Weimer, Professor David Jane, and Professor Jun Watanabe. Thank you so much for your expert knowledge. Thank you for answering the questions, and thank you for the lovely discussion at the end. This webinar was only possible due to your great expertise. I'd like to thank Diagnostic Green for actually sponsoring this webinar and supporting it so we could provide it free for anyone globally. And I thank ESSO for providing the beautiful platform where we can do education and training. And do go across to the website link that I've provided for ESSO, where you can find out other courses that are running and and other educational opportunities that are available. I thank special thanks to all the speakers. Thank you.
Thank you very much, Sana.
Thank you.